What is the most common question new surgeons ask about ICLs?
I think it's sizing for sure.
Definitely sizing. So sizing is critical for patient safety, for outcome. It can even affect the way patients perceive the temporary glare and halos. So it's very important to get sizing right. And luckily, it's never been a better time to become an ICL surgeon because there's so many sizing methods available now. So the three of us actually all are currently in different paths of life and are sizing ICLs differently. So I thought we'd share our experiences with sizing ICLs and also share a couple of the pearls. So I want to start with Gurpal here because in residency we might be a little more resource limited, but that also might be the way new surgeons start. So kind of talk to us about how you're sizing ICLs now and how it's going.
Yeah, and I think that residency is where it will begin for the new surgeons of learning about ICLs, sizing, and the different issues that may shake confidence for earlier surgeons. One of those with the issue of sizing is that at the University of Missouri, we're very lucky to have Dr. Landerneau, who is our refractive surgeon who does ICLs. And with him, we use digital calipers and Pentacam white to white, and then we use Stella for our sizing.
Are you kind of trusting Stella right away? Or are you hedging up or down?
Currently, right now, we avoid 12.1 and 13.7 as they're typically outliers. So we're more focusing and more confident with the 12.6 and 13.2 ICL sizes.
Then, we'll talk more about this in a second, but that's another reason it's helpful but not necessary to have more technology because, in my opinion, one of the few times ICLs will burn you is when you need the 12.1 or 13.7 and don't use it. But so, Dr. Nasser, you've had a lot of experience with ICLs in many different contexts and using different machines. So just kind of tell us what you're doing now and, give us your tips and tricks.
Awesome. Thanks, Matt. Thanks. It's always great. And yeah, please call me Taj, by the way. Thanks, Matt. It's always great to be with you all and for us to share knowledge with all of our colleagues. I went from having, access to every toy out there. We had 3 different UBMs. Life was great. I would nerd out between many different devices to moving to Dallas, and I'm taking over a practice now where I don't have access to any of that. So currently the way I size is I basically use a Pentacam white to white. So I use the manufacturer's nomogram, which also gives great results. But I also like to use a different method. But most importantly is sticking to one device. I think that's one of the advices and themes you'll hear here is you don't want to use one device on a Monday, a different device on a Tuesday. You'll drive yourself crazy. And then with the Pentacam white to white that I use, I also use the lasso formula. We have an IOL Master 700, so I can use that formula as well, which we can talk about in a little bit.
Yeah, can you kind of just tell us more about what goes into lasso, how lasso works?
Yeah, so you'll notice there are dozens of formulas out there, and if we go to history, we started with white to white external diagnostics. We moved towards UBM and anterior segment OCT, and the latest breakthrough really is artificial intelligence. And there's many different layers of artificial intelligence. Well, the lasso formula is using machine learning and advanced algorithms to give us a predicted post-op vault. I think that's one of the highlights of few formulas that are out there is you can actually have a number for the actual vault as you're sizing preoperatively, which gives me more confidence when I'm sizing ICLs. The good thing with ICLs in general, especially with the EVO model, it's a lot more forgiving. So long gone are the days where we're stressing out if it's less than 200 or over 750. The fenestrations, the whole aqueous dynamics is different. And, while sizing is crucial and very important, with the EVO ICL, we just have a lot more confidence in outliers.
So yeah, I love that point. I can't emphasize enough how tolerant EVO is to a huge range of vaults. In fact, would you tell us kind of the lowest vault after you've implanted and the highest vault, and if you've needed to address it?
Yeah, I'd love to hear from you all as well. The lowest vault, I've followed patients in vaults between 50 to 100, and then the highest I've seen as high as 1,400. Most importantly is you look at the safety parameters. If it's hyper vaulted, then what are you worried about? You're worried about angle. anatomy. So make sure you look at the angles, make sure you look for occlusion there. And then lower vaults, the risk of cataract formation. But we know the aqueous dynamics are different with EVO, and that anterior lens capsule is going to continue to get bathed with aqueous more so compared to prior. But definitely monitor those patients more closely, and if it's less than 100, then I'm scratching my head and just monitor them closely. And if things start to change or patients become symptomatic, I consider an exchange.
So very similar. I think the lowest fault I personally had was around 90. And just like you said, we know we call it the ball bearing effect, where the ICL is kind of sitting on a layer of fluid all the time. So it's much less risk, almost no risk. To my knowledge, it's never been reported in the literature of the ICL actually making contact with the crystalline lens, causing a cataract. And very similarly, so that that one was monitored, and we don't lose sleep over it. The other one was about, I think, 1400 as well. I'll put some pictures up here actually, but one point I'd like to really emphasize is everybody should not have a vault in between 250 and 750. Some eyes are large and actually need larger vaults. So the case that I always use as an example, the 1200, 1300 vault is perfect for that eye because the angles are still wide open. The physiology looks perfectly intact, and it's not causing any problems. So another thing I would say is just don't get too committed to the number because every patient's different. So just like Taj, we used UBM a lot at Parker's New Vision, starting with the ARC scan and the London Vision nomogram. Mm-hmm. That one's great. It also provides numbers based on each ICL size. The kind of limitation to that for me, like you were very astutely pointed out many years ago, was there's a lot of manual measuring, the calipers, risk for transcription error, risk for not being quite on the anatomy that you're trying to measure. So what we've recently adopted is ICL Guru, which just like Lasso is another machine learning driven technology. That is great because it allows for the text to take ultrasounds of the eye, and it's kind of all done internally. And it also provides an output. It also provides what I think is really cool, an ideal vault for that eye, because it can look at all the structures in the eye. So with that being said, that's been excellent. So what is on the horizon for us?
Yeah. So, to add a little bit to that, the Zaldivar ICL Guru is a great product, and that introduces what we've been working on as well, which is deep learning, which is a branch of AI. And I'll let Gurpal introduce deep learning and, how this idea came about.
Yeah, so what's under the hood for Project Vault here?
Yeah, the issue that we've noticed is with transcription errors and manual sizing, there's always that room for variability. So we wanted to take that out of the equation, and the way that we kind of were going about that was just using purely an image-based approach, using our deep learning models to predict ICL sizes. And right now, what we've kind of made together is with even just a single input of an image, we give an output of the recommended or the possible vault sizes for each lens, 12.1, 12.6, 13.2, and 30.7. However, we're now moving and migrating towards OCT because the UBM process is definitely cumbersome, and it's difficult for the patient and difficult for a private practice setting to consistently do that. And preoperative OCTs, like with AS OCTs, are a lot more prevalent in clinics and something that people have more access to. So we're now kind of training our next deep learning model to use ideally just a single image or multiple images to predict vault after that image. Yeah.
Yeah, so the idea with OCT is lowering the barrier to entry because most clinics will likely already have the hardware in the clinic. Can you tell us a little bit more about why OCT might be the future?
Yeah, and definitely, I wanted to add that when you're the surgeon starting out early with ICL, a lot of this could be overwhelming. You don't have to master all of this all at once. Stick with one thing in the beginning and then go towards what we're talking about is the extremely nerdy, where you'll have outliers, and we publish this. Percentage is about 7 to 8% in terms of outliers based on what definition you use. But what we want to do is we want to completely eliminate even that. And Rogers, the Zaldivar's ICL Guru has been phenomenal in helping with that, and we're looking forward to working on the OCT version as well together on that. The limitation of AI is it requires a lot of data. So the premise behind it is instead of measuring calipers, we're letting AI look at every single pixel of an image. So that's the basis of the idea. But it's going to take a long time for us because we need just an immense amount of data to master it. And from a patient experience, to answer your point, patients love reducing the amount of effort and sacrifice that they have to endure when they're in clinic. I mean, expectations are continuously rising, and to have to sit down and put an eyelid holder in your eye and immersion and all this other stuff. I mean, it works phenomenally, especially with, newer UBM technologies, which we use, and it can be fast, but still, for a patient, I wouldn't want you to be messing with my eye, man. I just want something easy, within a minute or two, get those pictures, and I'm out of that. So from a patient experience and staff experience, I would say, then it's been phenomenal to just use OCT.
Yeah, I'm one of the patients that have actually had the water bath, and it's a quick, easy experience with the ultrasound, but it can always be better. And if that's what we're all committed to is pushing the boundary and making the experience even that much better while retaining excellent outcomes and accuracy. Just to kind of finish up here, can you just tell us a little bit about how it's going with our OCT model?
Yeah, our OC model is showing very promising results, especially for the 12.6 and 13.2 models, because naturally those are the ones that are most implanted. However, our 12.1 and 13.7 models are a little bit have a little bit less accuracy because of the sheer amount of data. But overall, our results are very promising. We published our JCRS article on Vault UBM, and we're now actually pending publication for our OCT model in the same journal. So we're looking forward to that.
Yeah, so stay tuned. Like I said, this is a great community. We're all the refractive surgeons are very friendly. So you're not alone when you're starting out, and you have a bunch of people behind you that want you to succeed. Because I have ICLs in my eye, did my wife's surgery. I'm very committed to this technology as a great procedure, and definitely a procedure of the future. So thanks for tuning in. Thanks for joining us. And we'll see you next time.
Thank you.